if we could all take our seats. So we're going to have to contend with a little bit of background noise here, I'm afraid. But I'll make sure the speakers all speak loudly so that you can all hear. And we have 4 speakers, but we also have time for discussion, because I think this issue of fertility choice and HIV prevention is one where we by no means have cracked what we should be doing. I think it's a field where a lot of us are saying there are a lot of questions, both scientifically and programmatically. So it really lends itself to hearing a richness of debate after we've had the inputs. We've got 4 excellent speakers. My 3rd speaker is here, but she forgot to load her slides, so we've sent her scurrying off to the slide room. So she will join us just now, and if there's any delay, then I'll switch order and we'll change the order. So the first topic is one where some of you might have heard quite a lot of debate already, and it's a hot topic and it's a complex topic. The issue of contraception and HIV acquisition. It's also a topic that's had a lot of international discussion, with WHO taking the lead in that dialogue. Because it's complex, it requires a real clarity of mind to sort of set out what the issues are and challenge us. He's laughing. I know this man well, you can tell this from my build-up. But Ward Cates is somebody who I think gives the best exposition that I've heard on taking us through how we've got to where we're going and what the questions are that should challenge us. Ward.
Thank you, Helen, but I should say I learned from the master. Helen gives the clearest talk, and she was moderator, so she needed someone else. Let's go with this. Well, today, throughout the conference, we've had a variety of talks on this topic, beginning with Helen and extending all the way through yesterday's session, which was absolutely superb. And what I'm going to do in the next 15 minutes is just try and synthesize exactly where we are on this and then present to you what are some of the implications. Now, molecular level scientists always end with their acknowledgments and have casts of thousands of individuals. Epidemiologists at our population level acknowledge groups. And many of you in this audience are part of this, including my FHI colleagues in the audience, my co-moderators at the session, and everybody else associated with these particular organizations. This is truly a global village that we use in order to get this information. And it all starts, I can't emphasize this enough, this entire field starts with assuring that we ask a woman, each woman, what are her fertility intentions? Do you currently intend to get pregnant? And if yes, as we heard from Kenya yesterday, we set up a preconception counseling program that assures the best available outcome for that pregnancy. But if no, she doesn't currently intend to get pregnant, then contraceptive choices are hopefully available, and the choice here that we'll be looking at is hormonal or other methods and their effects on HIV acquisition. So in today's talk, I'd have to start with a history of the hypothesis. It's nostalgic. A brief review of the current evidence referring to what's already been discussed this week, how we got to the WHO recommendations and beyond, and then so what? What does it mean for women, and what does it mean for policies? Well, when we start the research timeline, literally it began 25 years ago in this town, in the Hilton Hotel up the street on Connecticut Avenue, with a presentation from Nairobi about increased risks in Kenyan sex workers. From that time on, synthesized yesterday, we have had multiple, up to 20, what we call secondary analysis, and a few primary studies addressing this question. In 1996, we had a major NIH consultation after some data from monkeys came out, and then in 2008, we had the first WHO hormonal contraception HIV consultation and report therefrom. But it really hit a crescendo in Rome last year, initially, when Renee Heffron, who we heard yesterday do an update analysis from the database, presented the data from the partner study, that got overshadowed a bit by the hoopla accompanying HPTN 052. So only those of us in the reproductive health field were sort of massaging the data at that point. But then when it was published, the global viral media took over. And it took over in Kenya. And with each iteration of spread, the information got a bit more blurred and a bit more dramatic and a bit more inaccurate. And this is what we face in trying to come up with accurate information about this highly complex topic. Well, what are we talking about? This was the study, discordant couples for acquisition purposes, looking at HIV negative women using hormonal contraception. And at the very top line, you see less than a quarter of women were using these methods. And what they found, which we heard several times at yesterday's session, was an increased risk for both combined oral contraceptives, COCs, and for injectable DMPA, both around twofold increased risk in this population. And then, as Chelsea showed us yesterday, when you meta-analyze these results according to the others that have been done, it forms an array of findings. She focused on the top 8 that we looked at WHO, and then Renee yesterday did sensitivity analyses trying to ferret out what was just DMPA, and her result here would go from about 2 up to about 4. But in these observational studies, they are replete with all types of limitations in terms of making causal inferences. Whether there's what we in epi jargon call selection bias, that women who choose different methods are just inherently different and do safer things, all the way up to the comparison group in these studies frequently contain more condom users than the hormonal groups, therefore perhaps driving the incidence of HIV in that group down with increased condom use, making an artifactually elevated increase in the hormonal groups. We wrestle with these. For those of us who make a living epidemiologically, we love wrestling with these, but it doesn't provide conclusive answers. Now, what about other contraceptive options? How are those actually available? We've talked a lot about injectables and DMPA. Well, the most effective methods, and this is a WHO slide, are those that are sort of forgettable. And that's these top lines, implants, IUDs, and sterilizations. But what is available in most settings, including many public settings in the United States, are these methods. The pills, injectables, breastfeeding, lactational amenorrhea, and male condoms. So those methods are really what are available, not those in the top line that are the most effective. We need greater method choice. I'm going to emphasize this again and again. But wait a minute, what about pregnancy, the alternative to less effective or no contraceptive use? The same database, analyzed by the now absent Nellie, but she'll be back, showed that, in fact, that same database, if an uninfected woman became pregnant, she had between a 1.5 after adjustment or a 2-fold increased risk of becoming pregnant. But again, observational studies, but the same database, are you risk? So really, what is an uninfected woman to do on the basis of these data? Well, if she uses injectables, she'll have less risk of pregnancy, but possibly, inconclusive evidence, more risk of HIV acquisition. But if she becomes pregnant, she has more risk of HIV, possibly acquisition, and those two, in fact, cancel themselves out, and more risk of pregnancy complications. So there are trade-offs involved to that, and unfortunately, she's damned if she does, or damned if she doesn't. So here, that's the setting for this gathering in chilly Geneva in about now 6 months ago. WHO uses a system mentioned very quickly yesterday, the grade ratings, that looks at all of these data and starts with randomized controls being the highest quality, observational being low quality, and they looked, as Chelsea guided us through, the 8 key studies and gave it an overall rating of low quality evidence overall. And that then forced this gathering to sort of focus on how do these low quality evidence affect the eligibility criteria for DMPA for this category of women at high risk of HIV. And so for some of the group, if we left it a category 1 and didn't change the existing recommendation, which was a category 1, no restrictions on Depo for women at high risk of HIV, that would let Depo get away with a clean bill of health. But if we moved it to category 2, that change implied that that evidence was strong enough in order to taint, that low quality evidence would taint Depo and might imperil its availability as one of the few effective contraceptives available in these public settings and low resource settings. And there was a total bell-shaped curve of opinion, just like, well, it's like life. And you had the strong category 1s and the strong categories 2, and most of us in the middle. So the statement in record time, Dr. Ambizo, for WHO came out in 2 weeks approximately after the meeting. Congratulations. And what it recommended was, because of the inconclusive evidence, no restrictions on Depo for women at risk, because the evidence was inconclusive, but with an asterisk clarification urging women who chose this method to strongly use condoms. And probably, in fact, definitely more important to me than even that particular rating were the programmatic and research recommendations that followed all of these deliberations. That based on this rating, clearly withdrawal of injectable contraception from programs was not warranted. That the method mix, remember the limitations we have, the method mix needed to be expanded and needed to be quickly expanded for women at risk of HIV, emphasizing condoms, and then the integration of programs to make these choices more convenient to clients who are accessing HIV resources as well. For research, we can't grovel in low quality evidence forever. We need some attempt to get higher quality randomized trials. Also a drive for developing multi-purpose technologies, dual-purpose technologies that can prevent both pregnancy and HIV in one method. And finally, further investigations of what are the underlying interactions at the molecular level that might lead to any possible increased risk if shown to be true. Well, the messaging around this was really difficult. We realized that actually as we were going home from that meeting. So WHO convened a follow-up meeting that was with community advocates, leaders, and national organizations. And they were really wonderfully candid discussions of the evidence in plain terms, interpretations, and attempt at messaging. And this report has just been published. If you click on WHO Montreux meeting or something, it will come up. It was published at the end of last week and contains some basic recommendations that I'll mention now. So where are we? What does this mean for women right now? Well, as I showed at the outset, the basic issue is, do you currently intend to become pregnant? Yes, no. Her fertility intentions drive the algorithm of the services we provide. Having contraceptive options available to act on if she chooses not to deliver is crucial. Without options, there really are very little choice. Accurate information, full accurate information about each method to each woman to allow her then to make her choice is fundamental to the informed choice part of informed consent. And I love the way Sharon reframed the question to the audience yesterday about, after having been informed fully, what would you choose for your, or what would you hope your teenage daughter would choose? Because your teenage daughter, you probably would not be choosing for your teenage daughter. Why? Because women's rights are fundamental to all of this, that it's her choice in her context about this. But what does this now mean for policies going forward? Again, only at the top. It's rights and justice, as Geeta Gupta told us about yesterday. Rights and justice are what an AIDS-free generation is all about. This now is an opportunity even more to make our case to all the countries and all the policymakers for increasing the method mix, for getting the regulators to approve more methods and getting them into our country systems. Having those methods available in country also means we have to make them accessible to where women have an unmet need for family planning. To have research on this multi-purpose technology, on these dual approaches, is accelerating. We heard about that at some of the sessions in this meeting. And finally, the integration of our services, again, as we've had whole separate sessions on, is a goal to make all of these choices more convenient for clients. So here we are. In conclusion, the recent findings are definitely concerning. Let's not have no doubt about that. But the evidence is not conclusive, and we remain in a sort of vacuum of ideologic uncertainty. WHO is continuing and will continue to evaluate these findings as they come in. However, reproductive health trade-offs are an inherent part of contraceptive choice, and even pregnancy itself carries its own risks. And now is the time to get on the bandwagon for method mix increase. Thanks so much.
Thanks very much. So what we're going to do, I think, we'll see how each speaker, but if they take up their time, then we'll save questions that on that speaker's talk to the end. I do apologize for the noise. I hope it's not too distracting, but I think all the speakers will have to really project their voices. So the next speaker, and that leads very nicely from Ward's talk, is Dr. Vivian Black from my own institute, the Wits Reproductive Health and HIV Institute in Johannesburg. And she's going to talk about fertility and HIV.
Thanks, Helen. It's a great honor to be here to talk to you about fertility and HIV. And certainly, a theme that's coming through this conference is that the times have changed. If I think back previously, if we had spoke about HIV-infected couples having children, it was completely tabooed and frowned upon. But the times have changed, and I would go so far as to say that it's medically negligent for healthcare workers not to engage with HIV-affected couples who are talking about fertility or family rights. This failure to do so is a human rights issue. It will continue to potentially continue to transmit HIV horizontally, and it will hamper our efforts to achieve elimination of PMTCT by 2015. We know, and Ward, a lot of what I'm going to say I think ties in very well with what you've said as well. HIV-infected couples or people have similar fertility desires to the general population. We know that fertility desires change with life events and life experiences, and this is certainly true. When antiretroviral therapy is initiated, fertility desires seem to go up. But also, with life-changing events such as changing a partner, fertility desires often increase. And one thing I have noted is that healthcare workers and researchers seem to focus on women, but men also have fertility desires, and they may influence the family hugely and fertility desire is a couple decision very often, over and above an individual's decision. I'm going to share some research from our unit. Sharia PhD doctoral thesis conducted in our unit of 850 HIV-infected women who were on antiretroviral therapy at the time of enrollment, and they were followed for a year. The first thing that we learned from these women is that their contraceptive use was probably not ideal. Only 32% of them were on hormonal contraception, among 742 who said they were not actively trying to conceive. 54% were using consistent condoms, and 15% said that they were using dual method. But certainly there was an unmet need of about 30%. This is not unique to sub-Saharan Africa, and when I looked at a study from Atlanta, Infectious Disease Clinic, which surveyed 127 HIV-positive women, I was quite surprised to see very high rates of sterilization. Amongst those who were sterilized, 18% of these women said that they would like to have children, and over half said that they were sterilized because they were HIV infected. And again, in this cohort, there was very, very low rates of hormonal contraception uptake. And this, I think, is a key message that comes from this, is that patient-provider communication is critical. And if we look at that in both of these studies, in the Atlanta study, only half of women had spoken to their healthcare workers about contraception in the previous year. And a third had admitted to either never speaking to them or only having spoken to them once in the previous 5 years about contraception. Another thing is that half of the women believed that the use of intrauterine contraception or hormonal contraception was unsafe if you were HIV infected. In the South African cohort, 93% said that their healthcare workers had spoken to them about condoms. So that message is getting through. But less than half said that their healthcare worker had spoken to them about non-barrier methods of preventing children. It is encouraging to note, although overall the numbers are still very low, where the HIV caregiver had spoken to the patient about hormonal contraceptive use or non-barrier use, the use was statistically higher. The consequences of poor communication, if we looked at this observational cohort from Johannesburg, that of the 850 women, there were 170 pregnancies in 161 women. 62 of these pregnancies were unplanned. 53 conceptions were on efavirenz, and of these, 36 women elected for a termination of pregnancy. And I think this is an absolute tragedy. If you consider that these women are in care, they are coming to a healthcare facility at least 4 times a year, and yet they are ending up requiring a termination of pregnancy. I think we are really failing the women in this program. There are special groups that need to be considered as well, and the first of these is perinatally infected youth or women. And this study of 252 women from UK and Ireland showed that among these 252 women, there were 42 pregnancies among 30 women. The median age of these young women was 18, with the youngest being 14. 81% of the pregnancies were unintended, and over half of their sexual partners were unaware of their HIV status. 36% elected a termination of pregnancy. 33% had detectable viral loads during pregnancy. And of those that delivered, one child was HIV infected. And this shows the outcomes if healthcare workers do not engage with the issues with their patients. The other groups that need special consideration are those with subfertility, as certainly there's some evidence to suggest that patients may engage in riskier sexual behavior, including relationships outside the immediate relationship and same-sex relationships. I'm not really going to engage with these other than to say that they would, options are available to them, and the options available to them would be largely the same as for non-HIV infected cohorts, with the same principles that I'm going to allude to overlined. This data that I've spoken about really speaks about the need for healthcare workers to truly engage with their patients, and not just once off, but repeatedly, so that people know what their choices are. And integration of family planning services into HIV is key. What do we do to the couple or the individual who comes to us and says that they would like to have a child? Well, certainly there are a number of variables that would determine how you deal with this, and that would depend on the resources available, also whether you're dealing with an HIV-infected man, woman, or couple. All patients would need preconception counseling, and in this counseling one could explore the reasons behind why they are choosing to have a family. I would certainly encourage disclosure of the status and support couples to do this. Informed decisions are important. Understanding the choices available to them and the risks of the various choices and the costs of the various choices. They should consider the consequences of failure to present horizontal transmission and what that would mean. And this is also an ideal opportunity to optimize the health of both the HIV-infected partner, but also the woman who is potentially planning a pregnancy, bearing in mind substance use is harmful to pregnancies, and optimizing nutrition. I've highlighted here the minimum preconception medical management. This, as I said, is the minimum. There is much more one can do, and depending on available resources, you may build on this to provide a different level of care. But certainly, I would want to exclude any sexually transmitted infection within the couple. And this can be done on clinical examination and through syphilis serology testing as a minimum. I'd want to exclude AIDS. I would do this by CD4 cell count testing, but also a thorough clinical examination. Those who are on antiretroviral therapy should ideally have an undetectable viral load, and one can screen for infertility through history. And then the usual pregnancy tests can be done. Based on your findings, one would optimize the health of both the HIV-affected partner and the couple. Any medical illness should be treated, optimized, and one can use various strategies to determine the ovulation cycle. Again, one can purchase kits. Some couples opt to do that, or one can use timed ovulation. I think those are the two most common used methods in our environments at any rate. If you have an HIV-infected male with an HIV-uninfected female partner, for me, ideally, your infected partner should always be on antiretroviral therapy with a suppressed viral load. And if you have available resources, one can use assisted techniques such as sperm washing, which probably costs between $150 and $200 per, and it's quite a simple technique to do. One thing that people sometimes overlook, though, is one attempt does not always mean success, and you may need repeated attempts, which will certainly add to the complexity and the cost. In resource-poor environments, couples may attempt natural conception, in which they will use condoms for the duration of sexual activity, except during the fertile period, in which time they will practice unsafe sex. Barreiro published criteria in 2007 around natural conception, and I just want to highlight two issues. The first is that the responsibility of adherence rests with the HIV-affected partner, but the decision to consent to having unprotected sex should really lie with the HIV-uninfected partner. If you're dealing with an HIV-positive woman with an uninfected male partner, again, antiretroviral therapy should be used, and suppression of viral load would be ideal. But there is, in essence, no need to expose the male partner to HIV, as one could use conception using intravaginal or intrauterine insemination. This obviously would be a couple choice, and based on the 052 information, people may still opt to have natural conception, and this again would be an individual couple's choice. It's quite easy to manage your HIV co-infected couple. Ideally, you should optimize patient health, optimize HIV health, avoid any teratogenic drugs, and the couple can continue with natural conception. If one is unsuccessful after 6 months, certainly the previous literature would advise it would be unhelpful to continue trying to conceive without some sort of intervention, because you may not be successful, but you will potentially could be continuing exposing your partner to HIV infection. And investigations at this stage may be warranted with appropriate counseling. Remember, during interventions, which should always repeat test your HIV unexposed partner. Where conception is successful, again, repeated testing of the uninfected partner is important, particularly the woman, because if she happens to seroconvert during pregnancy, she needs to have interventions to reduce the risk of mother-to-child transmission. And as Ward has alluded to, and we will subsequently hear, pregnancy itself may increase the risk of horizontal transmission of HIV. So condomization, once conception has been successful, is important for the couple to consider. And remember, and I'm not going to talk about PMTCT interventions, but one wants to reduce the risk of mother-to-child transmission to the maximum. And I would advocate using antiretroviral therapy, but would largely go with your regional guidelines. I would like to thank some of my colleagues that I work with who always inspire and support me in the work that I do, not least of which is Helen sitting next to me. And also I've put on the slide some further reading, some further guidelines, so those of you in the field who would like additional information can look at that. Thank you.
Thank you. So again, if you can hold questions, we'll move on to it's a flow, as you can see, of thinking here. So both Ward and Viv have referred to the issue of pregnancy and HIV acquisition. And very appropriately, we've got Nelly Mugo, who is going to provide us with that data. And she's published, as many of you know, on this topic from her own cohorts. Nelly.
Good morning. Thank you, Helen. Helen was part of that work on the risk of HIV acquisition. And very briefly, I'll talk to you about pregnancy and HIV acquisition. A lot of it is old data, and I'll present some of our own data that Helen has referenced to. So I'll talk about fertility rates, the association, the plausibility, and the evidence of increased HIV incidence in pregnancy and breastfeeding. So I think through this season, we've talked a lot about the fact that women are very vulnerable to HIV, and they represent more than 50% of those people who are infected, and 42% of new infections. And this is within the reproductive years of women. So this really makes this issue important if the majority of infections are occurring amongst young women. I just thought, as we're talking about this, is to remember it's really part of MDG 4 and 5, issues around maternal health and neonatal health when we talk about risk of HIV acquisition for women and children. These are old slides. I think they come from South Africa, and we see that peak HIV prevalence, again, occurs around ages 24 and 34. And we know that the majority of women, this is the years that they're having babies. There are high fertility rates in sub-Saharan Africa. This graph really shows a drop, but still 5.3 is high, which means that women spend many years pregnant within their life. So does pregnancy increase HIV risk? There are physiological reasons why we believe this could be true. High progesterone levels can induce systemic and immunologic changes. And unprotected sex that takes place when people are desiring pregnancy increases that risk. And we know from our own cohort of serodiscordant couples that they have told us again and again that they would rather risk getting HIV than stay without a baby. They say that when they found they had HIV infection, they still have to negotiate family issues, pressure from family members to have children. For many women, you cannot stay married if you don't have a child in the marriage. So the issue of HIV risk is the issue of female vulnerability for acquisition and the risk of transmission to the male partner when the woman who's HIV infected is pregnant. I looked at data on incidence, and it started very early. Mitso from Zimbabwe started reporting very high incidence as far back as 2001. And we have had continuous evidence that there's high HIV incidence through pregnancy and breastfeeding. So male to female HIV transmission, we've had observational studies showing about a twofold increased risk during pregnancy. There's only one trial, the contraceptive study, that didn't show a difference in incidence between non-pregnancy state and pregnancy state. For female to male transmission, there isn't much data outside of our own reports about increased risk to the male partner from the HIV-infected pregnant woman. There was an early study done in the 1990s that showed that there was increased HIV shedding during pregnancy. As has been mentioned already, acute HIV infection in pregnancy is of key concern, and it confers about 26%, and in some data sets, 29% risk for the newborn baby. Now, we know that in majority of our setups, we only test women once in pregnancy to make the decision whether or not we should have PMTCT algorithms for her. We do not do repeat testing. And even when we see women postpartum, we rarely ever test them again. So when we have such high incidence of HIV and a transmission risk of 29%, I think this is a great cause of concern and will be a big lost opportunity as we move towards eradication of neonatal HIV infections in our setup. So I'll give you a summary. I've presented this data before about pregnancy incidence in our herpes trial. This study was across 14 sites in both East and Southern African region. One of them was Helen's site. And we had 3,321 eligible couples, and we looked at the seroconversions between male to female transmission and female to male transmissions. And we had the opportunity to look at the linked infections when we were sure that the transmission was within the partnership, and look at the difference in incidence during pregnancy and outside pregnancy. From this slide, you can see that there's a twofold increased risk for male to female transmission. And this held true. This risk wasn't observed after adjustment. The statistical significance went down. But for the female to male transmission, even after adjusting for confounders, the significance was still there. It retained at a twofold increased risk. So as I've said before, the data showed a twofold increased risk for HIV risk during pregnancy for both the uninfected pregnant woman and the risk of the pregnant HIV-infected woman to transmit HIV to their partner. I think of key importance is that even if we say that the significance went down after adjusting for confounders, the key issue is that that infection does take place, that the risk exists to the woman, that she has an increased risk of acquiring HIV. So if we're thinking about how to manage this, we cannot say that it's simply behavioral. We can adjust the behavioral issues around it, but we cannot ignore it. And I think I've already talked about the issue of social-cultural pressures and desire for pregnancy for serodiscordant couples that outweighs the risk and fear of HIV infection. And interestingly enough, this is true for both the male and the female partner. Very often, we think it's the woman who has to conceive, otherwise she loses the marriage. But when we've talked to the couples in qualitative research, the same pertains to the men, the HIV-negative man. They're willing to take the risk of acquiring HIV so long as they can attain fertility within their partnership. I've often felt, after spending this amount of time with serodiscordant couples, that HIV is a virus. It's, if you're in a relationship, your partner doesn't change because they have a virus. So whether it's a man or a woman, you don't simply change partnerships. And this risk profiles exists, and we have to take care of that for both men and women. So in conclusion, I've said that women in sub-Saharan Africa especially spend a substantial number of years pregnant. And it exposes very high risks of HIV to both mother, baby, and husband. And male partners are often not factored into perinatal HIV strategies. I know we talk a lot about couples counseling, but I'm not sure how many of our antenatal services actually cater to men. And they look lonely in our clinics when I see them. And sometimes when the woman comes in with a man, you know, or I ask her, where's your husband? She says, he's sitting outside, looking very shy. It's the one environment men lose their voices. So we need to have them have their voice, and when they turn up, to know that they're welcome to the clinics. I think there's also a need for advocacy and community level to encourage men in those regions in the world where they're not involved in issues of pregnancy to know that they are welcome to take partnership with their partners in going through pregnancy and safe delivery for both themselves and their babies. So thank you very much, FHI, for inviting me to do this, the conference organizers and all of you, and my fellow investigators in the partners studies. Thank you.
Thank you very much, Nelly. Nelly, it's always a pleasure to hear because she mixes science with anecdotes from the field seamlessly, and it makes it very real. Thank you very much indeed. And we'll come back, as I say, to the discussion. So our final speaker on this panel is Angela Nabiba, who's from the I-based training program based in the UK, but is from Kenya. And she's going to talk about sexual and reproductive health rights for HIV-positive women. Angela.
Thank you very much, Helen. I wear many hats, but in my everyday life, I am first and foremost a mother living with HIV. I've been diagnosed I think it's about 18 or 19 years, I forget as the years go by. In my other life, I am a training advocate, but also previously before that, I worked as a project manager for Positively UK, which is an organization that provides support for families living with HIV. And during that time, I led on the development of a project titled From Pregnancy to Baby and Beyond, which was aimed at providing targeted support and a sustainable model of education, information, emotionally practical support for women living with HIV, either diagnosed HIV positive antenatally or those who are planning to start families after an HIV diagnosis. What was unique about this project was the fact that it was led by an advisory group of healthcare clinicians and women living with HIV, where mentor mothers were trained to provide support to the women living with HIV in order to complement the clinical care that they're already receiving. So what I wanted to say, I just want to start off by thanking the organizers for inviting me to come and speak about an issue that is really, really close to my heart and one that I'm particularly passionate about. So what I'm going to do is I'm just going to take us back, just remind us a little bit about what SRHR are. I'm going to use SRHR because at the risk of tripping over my tongue if I keep saying the full term. So I'll remind us a little bit about what they are, what they mean for people living with HIV, give us a few examples of how these rights are, how they're protected, where they're sometimes violated, how we can continue to protect them, make a few recommendations, and then I'll finish. So we all know very well that these rights are the rights of people to make informed choices and free choice with regard to their own sexuality, reproductive and health and well-being, but of course this is on condition that these rights do not infringe on the rights of other people. They also include the rights to access information and education and other services in healthcare. Now, when I was growing up, like many other young women, I dreamt of having a decent lifestyle, a stable relationship, and 4 children. So when I was subsequently diagnosed HIV positive in my early 20s, I kind of thought that this dream would never materialize. However, years later, and being lucky enough to be living in the UK where I accessed integrated services to prevent vertical transmission, I'm proud to say that I'm obviously a very proud mother of a 13-year-old who was born after my diagnosis. I haven't met my dream man yet, but I do have a job, and so I guess 2 out of 3 isn't doing too badly. So, but on a serious note, though, I really am acutely aware of how extremely crucial these rights are for women living with HIV. So what are these rights? Well, people living with HIV have always wanted and deserve to have the right to have healthy, satisfying sexual reproductive relationships, to bear and raise children if that's what they choose to protect themselves and their partners from both unplanned pregnancies and STIs, and also to have safe legal abortions if that's what they choose, or if circumstances within their lives dictate that that is the right option to go for. I'm not going to go through too much about this, but these key rights are clearly articulated in the ICW, which is the International Community of Women Living with HIV, and GNP+, which is a global network of people living with HIV. They have a guidance package on advancing the sexual and reproductive health and human rights of people living with HIV, and they clearly articulate all these rights. But we also know that these rights are currently protected in the Millennium Development Goals and in several instruments that enshrine SRHR and wider rights to equality, including, I'm just going to mention a couple of these, the 1994 International Conference on Population and Development and Program of Action, which is also known as the Cairo Conference. This was the first and most comprehensive international document to embody the concept of reproductive health and rights and sexual health. And we also know that they're protected in the CEDAW, which is the 1979 Convention of the Elimination of All Forms of Discrimination Against Women. This was a binding treaty so that any countries assigned to it are committed to ensure and respect for women's rights and women and girls' rights and fundamental freedoms. So we know these rights are protected, but unfortunately, and despite all these protections and some 30 years into the epidemic, sadly, these rights are still being violated. I'm just going to give you a couple of examples. And these are some reports that have been written which document some of these rights. The first report I'd like to mention is one that's titled "Robbed of My Motherhood." And this gives concrete examples of coerced sterilization in Namibia. As a follow-up, the Open Society for OSF, and I'm sure most of you know what that stands for, have also done a follow-up DVD which charts stories of torture in the health services, and they also do have one of the women who actually underwent coerced sterilization who was featured in the DVD. There's also another report which gives examples of these violations from Asia, and it's called Positive and Pregnant, How Dare You? And the third report I'd like to mention, I'm sure Nelly probably will know of it, is the one that's titled Realizing Sexual and Reproductive Health Rights in Kenya, a Myth or a Reality. It was a report of the public inquiry into the violations of SRHR in Kenya, which was done by the Kenya National Commission on Human Rights. So we also know the women's rights are violated in terms of the real risk of being prosecuted, and especially for, there's examples from Sierra Leone where women run the risk of being prosecuted simply because of being HIV positive and pregnant. Now, I chose to have a baby after my diagnosis, and it was for very personal reasons. One of them was the fact that, as Nelly already mentioned, I did want to exercise my right to have a baby, and also the fact that before I was HIV positive, I also always had maternal instinct. I wanted lots of children. So I wanted to exercise that right, but even more importantly, I wanted to have a child because I didn't know what my prognosis was like, and I didn't want to die and leave nothing of myself behind. Now, for me to choose to have a baby after my diagnosis, does that make me a criminal? And I'll leave you to mull over that one. So we do know that these rights can be protected. I'm sure most of you know about these, and we know that there are already programs which exist which actually ensure that these rights are protected. However, I just want to mention a few of these just to remind us in case you want to take away one or two messages. So we know it's extremely important that we train and sensitize healthcare workers to respect the rights and support all people living with HIV, including their colleagues, volunteers, and clients. And it's also really, really important to screen for gender-based violence, which is often heightened in pregnancy anyway, even without an HIV diagnosis. It's also very important to provide necessary information and services for women living with HIV. So we're talking about the integrated services that were already mentioned before, which provide family planning, protection from STIs, psychosocial support, financial support, housing, so holistic integrated services. And there's lots of models of good practice that exist, and I'd just like to mention three. I already mentioned the project that I worked on in the UK. But we also have lots of positive developments, such as the Mamas Club in Uganda, and of course, Mothers to Mothers, who have very good programs in 7 of the global plan countries. So it's also, it goes without saying that we also need to have better laws, policies, and guidelines which protect confidentiality and provide information and support for women living with HIV. There's a couple of programs like the SHE program, which stands for Strong, HIV Positive and Empowered. They provide funds and support for groups of women living with HIV to continue their wider advocacy in community and with policymakers and people like police and social services. And of course, one resource that I really feel is important is called Stepping Stones Plus. And this gets all community on board with understanding what their rights are and how they can continue to support people living with HIV within their communities. So what works? We've already heard that integrated services work, and a new study published in the Journal of International AIDS Society highlighted lots of successful interventions that are already in place, which work to meet the SRH needs and desires of women living with HIV. So we're talking about those that provide contraceptives, family planning, cervical screening, etc., those that ensure early postpartum visits and provide family planning and other information and services, and of course, very, very important, those that provide youth-friendly services, because we know there are not that many services that are adolescent-focused and centered. So it's important to provide those ones. Those ones are the ones that actually work. Services that provide the support and information, skills building, and also supporting voluntary disclosure. Those are really, really key. And of course, services that promote male and female condom use for dual protection against both pregnancy and HIV. And also very important, of course, services that provide ARVs when needed, which, if well supported, can increase protective behaviors, including condom use. However, provision of ARVs should not be dependent on women also accessing other services. And of course, as was mentioned earlier, we need to have services that provide meaningful engagement of men and boys in gender transformative ways. So, just coming to the end now, and again, as we're talking about the sexual reproductive rights of women living with HIV, for me, I feel that it's extremely important that we always support and enable women living with HIV to be involved in making decisions, in informing services, etc. Well, again, I'm going to mention the ICW and GNP Plus package of advancing sexual reproductive rights of people living with HIV, because they clearly articulate how you can actually do that, how you can involve both women and men living with HIV in being involved in informing services. We also need to continue supporting women living with HIV to monitor experiences of programs and policies in order to shape and continuously improve them. Now, as women living with HIV, we are a key resource in integrating services. We have both the skills, the abilities, the expertise, and the invaluable lived experiences to actually make services work. It's also very important to ensure that we, as women living with HIV, are part of decision-making bodies such as technical working groups and national AIDS councils. So bodies that make decisions about policies, programs, and where and how resources are spent. And so to reiterate, it's not just enough to consult us when you're planning services. We need to be meaningfully involved in the planning, the development, the delivery, and the monitoring of services. So I'd like to end with a quote from Stephen O'Brien, who is the Parliamentary Undersecretary of State for the Department for International Development in the UK. This is a quote which he said just before the recent UK Family Planning Summit. And for me, it kind of summarized a lot of what I'm trying to say this morning. And I'll let you read it for yourselves. Okay, and then just very, very finally, before I leave, I'd like to share with you an image which I saw when I was putting this presentation together. This is an image which really made me smile, but one which captures in its own very unique way just how extremely crucial these rights are for women living with HIV. Thank you.
Well, thank you. I think those are four absolutely excellent speakers, and what was, I thought, very nice was how each one led into the other. And I was, Angeline, your comment about I wanted to leave something behind of myself. I think that's just absolutely right. I think all women have that feeling. Not all women, but many women have that feeling. And that doesn't matter what your HIV status is. So against that background with those 4 excellent talks, can I invite people to come to the microphone? You can ask questions of the speakers and or make comments about this field, which fertility choice, quite frankly, in the way we respond to it, has not been well responded to. I think that we can see this from the presentations we've had. So all comments are welcome. Mike.
Thanks very much, Helen. I would like to add my thanks to the panel, very rich and informative. My name is Mike Mbizo from Zimbabwe, currently with WHO Department of Reproductive Health and Research. Certainly what is emerging, I see 3 things here: contraceptive coverage, widening choice, and universal access to family planning, and a rights-based family planning framework. But I think a major issue that also often confronts us within WHO and from the data is that of barriers and bottlenecks to uptake of methods of family planning. Issues or methods like implants, IUDs, and some of the work going on in the vaginal ring, the potential for the vaginal ring. I really would like advice from the panel in terms of, one, what are the key barriers to some of the methods outside the mainstream and bottlenecks? And two, what suggestions in terms of way forward for widening contraceptive choice, coverage, and access? Thank you.
Excellent question. Who would like to tackle that? Ord, do you want to start? I think it's on. You don't have to touch it.
Oh, great. Okay. Well, thanks, Mike. And as has been part of a rich discussion during many of the different sessions, even at this conference, it's regulatory barriers that we need to overcome to get methods approved in country and therefore available. It's provider barriers and myths that the medical eligibility criteria are intended to overcome. It's client barriers in terms of myths and inaccuracies in terms of information that has been fed to them through a variety of circles. Anyway, and then there's sort of availability of new methods that are easier to use and available through their routine facilities. But all of us have, and on the panel, have more experience with actually confronting barriers in the real world than I do.
Nelly, do you want to add something from a real world?
I think Ward has said most of it. And just even access to that method mix. I think if you go to the peripheral clinics, what you will find most commonly is injectables because they are easy. And the provider barrier that's been mentioned, you know, the time taken to insert an IUCD, cleaning of speculums. So I think a lot of work and commitment and funding needs to be put in. But what FHI tried to push the IUD some time back. I think you made effort in that direction. And you know, that fear of infertility and STIs, I think the teaching, even in medical schools, has not changed. So maybe that's where we need to start doing the undoing.
Thank you. Yes, please.
Hi, Lynn Matthews from Massachusetts General Hospital in Boston. And I just wanted to, I guess, make 2 comments that touch on things that multiple people talked about. In Dr. Case's presentation, sort of the first step in all of this is really a patient-provider interaction around what are your fertility intentions. And I think the way that question gets asked is sometimes not amenable to getting an accurate response. And so sort of, are you planning to have a pregnancy is a pretty specific question, and I think it needs to be more of a conversation that includes the partner's ideas about pregnancy, the woman's ideas about pregnancies, maybe other pressures they're feeling. And it's not, I think planning sounds pretty specific, and we work with a lot of people who say, oh, I'm not planning to have a pregnancy, but I'm having sex and I'm not using contraception and I'll be happy if I get pregnant. So I think it's just one of those patient-provider interactions that, like many patient-provider interactions, that we need some work And I think the other piece of that patient-provider interaction is I think that doctors are coming around and are feeling like, yes, people with HIV can have kids, and that's fine. But the people we're talking to don't necessarily know that. And so when we ask that question, they may not answer honestly because they're afraid someone is going to shout at them and say, no, you shouldn't have children, you have HIV. So I think it's an area pretty ripe for work on trying to improve patient-provider interactions around this topic. And then just one other thing I wanted to say quickly, which came up in Nellie's fabulous plenary 2 days ago, but didn't come up today yet, is that this may be people who, in serodiscordant relationships, who want to have children, may be key people for PrEP around the time of conception, particularly if the infected partner doesn't want to take treatment or isn't likely to adhere to treatment or doesn't meet local criteria for treatment. Thanks.
Viv, do you want to just comment on the latter part about either part of the comments made?
So I agree with those comments, and those observations are spot on. I've been thinking a lot about the PrEP use. Certainly, I think if you've got a known discordant couple, the optimal intervention would be to provide antiretroviral therapy and to suppress the viral load of the affected partner. But failing that, I think PrEP would be an alternative. But that would be the second choice, not the first choice.
What further research would need to be done for that to be regarded as safe in the field?
So, I mean, there's been very little studies around PrEP and, well, certainly conception. It's also in the combination. So if you have somebody who's on antiretroviral therapy, does the use of either PrEP or post-exposure prophylaxis add any transmission reduction benefit? I think that's an unknown. And obviously, the adherence issue, the long-term issues, is an ongoing question.
Please.
Seema Yasmin with the CDC's Epidemic Intelligence Service. This is a question primarily for Dr. Cates. So at CROI, Croatia referred to the WHO statement as being less than definitive and perhaps not so useful for certain countries. And given that many resource-limited countries rely heavily on WHO guidance to inform their national policies, what do you think is the impact of this particular statement on resource-limited countries? And are there any plans to review and revise the advice?
Fascinating. CDC adopted the exact same statement, I guess, but for a resource-rich country, it might have different implications where contraceptive options might be more widely available. In terms of what implications that guidance document has on resource-poor nations, I think the main implication is that it continues to allow injectable contraception to stay in programs, and at the same time, we hope, puts pressure on national policies to increase method mix so that we could, in the long run, scale down perhaps that if the if the evidence continues to show concern. That to me is the main implication. The first questioner sitting in the audience is the person who actually oversees WHO on that. But once again, the other issue that we've been struggling with and don't have a perfect answer for is how do you message in terms of giving full and accurate information? How do you message the etiologic uncertainty? And as you in the EIS learn all about the principles of etiologic reasoning during your training, if you could help us in terms of explaining this highly complex situation, that would be great.
Thank you. Please.
Hi, Jonathan Fuchs from the San Francisco Department of Public Health. Thank all the panelists for superb talks. A question for Ward about counseling and the provision of reproductive technologies in the context of our large-scale efficacy trials, testing biomedical prevention strategies. What are your recommendations for current researchers in terms of ongoing studies and for planned studies in how we counsel and through the informed consent process in providing these technologies as we move forward?
Dr. Reese, number one, is running the preeminent trial that involves exactly the question you asked, Jonathan, which is how do you counsel women about methods of preventing pregnancy in a situation where limited options are available. And what you do, as with any situation, hopefully, is give very accurate information about the available methods so that they can choose among what they have in front of them. And at the same time, as she is doing, start pushing for approval of additional methods that then can be inserted into that choice for which accurate information is provided. There's nothing more important than the way Sharon rephrased the question yesterday afternoon for anyone who was there. Namely, our goal is to have as many options available as possible, to provide the information about the pros and cons of those options, and then the woman makes the choice about which method is best for her particular setting. And it's also fitting, and I don't know if Jared wants to talk, or others, about even just designing right now for the trials going forward. What are the messages, given the inconclusive evidence, that we will be giving to women? And in fact, anyone planning a prevention trial, what we really ought to start doing is sharing this information as to how we're messaging in our informed consent, as well as in our informed choice, two being very different issues, how we're actually explaining that, so that we can always learn from each other as in terms of what works in the clinic. You guys are the ones who are on the front, the front lines of implementing this. How are you doing it?
It's a very, very challenging question. I don't think we've gotten to really doing it that. Unpacking the WHO conclusion is a challenge. And I'm not sure I have an answer to that question right now. But I think that I just wanted to go back to what Matthew stated, that I didn't mention that, to think about what the tools we have now that we can give women in pregnancy to protect them from transmitting and acquiring HIV. And I think that the other thing we had during the WHO meeting is that all contraceptives are safe in HIV-infected women. So for that arena, we don't have any controversy.
Angelina, from a rights perspective, it's me, sorry. From the rights perspective, I mean, this issue of how do you tell women? I mean, what from a sort of women's rights perspective would you want us to do with the ambiguity of the information that Ward presented?
I think for me, what is key is ensuring that the women have all the information. And again, as already mentioned, this is what is available. This is what we know about it. This is what we don't know. Because women really, I mean, when given the information, we're able to make the right choices. And I'd rather have the information and the choices to actually be able to make a decision than not. So I think just being given the right information, very honestly, this is what is possible, this is what isn't, we decide.
Thank you. Please.
Thank you. This was a really excellent panel. It was really good to see the discussions of fertility for HIV-positive women. A lot of really, really good stuff. I want to discuss to follow on the discussion of DEPO and its the studies. And yesterday we heard a panel. One of the questions was, there was biological evidence presented about difference in those that the women that were using DEPO and the women that were not. I wonder if that evidence, you could explain, Ward, whether that would worry us. Does that evidence, that biological evidence, in any way go towards an understanding of the risk? That's my number one question. The second question is, I am an advocate of choice. I think I've worked on this issue for a long time. Just had that's the thing I believe in for women. And we are autonomous, and as Angelina says, we make our decisions with information. But there is a way in which you have to evaluate medically and take responsibility. We also need to understand the science and the risk involved, and at what point you do not want to go on providing things. And that's the question here for me. So then the question is, if we look at the studies of DEPO, have we looked at young women? Because when you look at the Heffron study, those are partners. Now, I don't think that most women under 18, and I may be wrong, but many, many women under 18 would not necessarily come in with partners. So I wonder if the Heffron study, just in that way, may be kind of biased or, you know, selective for slightly older groups. I think that when we look, and this is something that Zena brought up yesterday, we look at some of the other studies that were in that evaluation of risk, that they're with older groups. So the question then is, if you look at the data that you have today, and you look at the particularly young women who are biologically or at greater risk, then can you still go forward? I'm not saying that pregnancy isn't a risk for AIDS. I'm not saying that maternal mortality might not be a risk, but if we just take DMPA, Depo-Provera, can we re-examine the way that risk is evaluated? That's my question to Ward or to.
Sure. Thanks, Ida. Two questions as I sort of discerned them. Number one, the biologic data, and then number two, a focus on youth. There are a whole host of biologic findings over the years, whether they be immunologic, as we heard yesterday, whether they be anatomic, such as cervical ectopy, whether they be microbiologic, such as other STIs, whether they be virologic in terms of types of effects on the virus itself of steroids. Those are all put forward as part of the etiologic reasoning process as either supportive or not supportive of a study outcome. Actually, a lot of those studies are not as conclusive as we'd like in one direction or the other. And for example, even with those immune markers we saw yesterday, there are lots of studies of immune markers with lots of different immune markers either implicated or not implicated in that, in sort of the susceptibility realm. With regard to youth, you know, the question is that this is a prime population to examine. I think one of my colleagues, Charlie Morrison, will be having more data to look at youth through a meta-analysis that he's doing, and we need those larger databases in which to come up with any type of reasonable recommendations. In terms of pulling a method, I guess the third was, when do we have enough evidence to pull a method? When do we have enough evidence of harm? And actually, there really is in all countries, a regulatory body that is responsible for doing that when the data are presented to them. So there is a process globally that allows that.
Jill Gay, whatworksforwomen.org, and my question is to all the panelists. In resource-limited settings, how can we restructure health services to create a safe space for preconception counseling? It's not going to happen in ANC. How do we do this restructuring?
Viv? That is a good question, yes, Wood. As we have to shift our services to non-primary healthcare providers. I think conversations need to be had with your doctors and your nurses, but I think we need to start bringing in the HIV-infected couples themselves, particularly those with experience, and maybe create those forums and share information as much as possible. We have a lot of challenges around this. I mean, if I think of our experience in South Africa, where we have potentially 300,000 HIV-infected women coming through our antenatal clinics a year, it is a huge task, and we currently use our lay counsellors, but their level of education and the complexity and the time that they have, and I don't think that that's going to be the solution. I think we have to look at other strategies, and my immediate thought would be we need to use the patients themselves.
Nelly, do you want to comment?
My opinion on this is that a lot of these things need to go to pre-service training. That if you sensitize your nurses and your doctors and your providers very early, that young women or people who are going to conceive have these issues, and wherever they are, wherever they meet them, they need to think about this and address them. You probably have a larger audience for them. As you were talking, I was thinking about the family planning clinic, but a lot of women get pregnant, they're 28 weeks, and then they turn up to the clinic. So that would only be effective for the second pregnancy. The other issue, I think, when the question was asked about the things that we can do to implement the WHO guidelines, as I was thinking about it, is that we need to integrate our HIV services in our family planning clinics, because if you walk around, there's not much HIV testing going on where contraceptive is given. And the providers in family planning clinics, everybody has their tunnel vision. They're not the HIV people. They don't do testing. They don't do counseling. And if we are really saying, if we're actually going to actualize the recommendation by WHO, the provider for family planning needs to have some form of criteria to say you're at risk, because we're saying for those at risk. Now, not every woman is at risk. So many women can safely use Depo, but does the provider know how to pick out who is likely in any manner that they need this messaging in a strong way? Because if you give it as a general message, it doesn't really hit home. So I don't have a perfect answer for that question, but my general thinking now has gone to that we must do more pre-service training and sensitization for prevention. I think that doesn't happen.
I think just to add that in South Africa, we're developing a contraceptive policy, but it's now the contraceptive and fertility policy. And we ideally want to have fertility counseling as a step. And to achieve that, we're looking at, as Viv said, using lay health workers, bringing them much more into the system, because certainly the current nursing staff would not cope with this load. Yes, please.
Hi. I'm Stephanie Marhefka from the University of South Florida. And Nellie was just talking about pre-service counseling and training. And I think that's clearly a very important issue. I'm wondering what models are there already in place, and is there anything evidence-based that will help to guide those kinds of services so that providers are better able to support women in these choices?
The only thing that I know is currently going on at my university is that they've taken HIV training to pre-service in a very directed manner. So, but I don't know how much prevention is in their packages. That's the other problem. So how do we distill to make sure that when these things are happening, the prevention messages are in there? Because as providers, we're very keen to treat disease. We're very interested, in fact, in very complicated disease. But prevention is not given the space that it needs.
And stigma reduction.
Yes.
Angelina, do you want to comment on that?
Yeah, well, what I wanted to say was some of the models of good practice that I mentioned before very much utilize community-based treatment literacy, as well as, for the program that I was working on, what we did was we trained up the peer mentors who were then able to provide preconception advice, issues around pregnancy. So taking on what you said, the burden from the healthcare providers, because we know that even with the best will in the world, no one healthcare provider can provide women with all the psychosocial support, the clinical support, and that women will present with a lot of issues upon diagnosis, or if they're diagnosed antenatally. So I think the community is such a valuable resource, and there's so many positive people out there who have the skills and the resources, and it works. I mean, you can look at the example of Mothers to Mothers, you can look at the Mamas Club, they're there. And there are, we do have an evaluation report of the program that I did, and I'm sure there's lots more information around. But I think don't underestimate the value of community peer support.
Thank you.
Thank you. I'd like to get through the last 4 questions, so very briefly, please.
Gabriela Paz-Bailey from the CDC. I have a question for Nelly about the increase
HIV transmission from an infected pregnant woman to her partner. You mentioned that this was still important after adjusting for behavioral factors, and I suppose that includes reduced condom use during pregnancy. So what is known about the biological mechanisms that would explain the increased risk of transmission?
There's one study that was done in the early 90s that showed that there was increased shedding, HIV shedding during pregnancy. I think that's just one of the pointers to that direction. And you know, the whole cervical area changes around pregnancy. That would help, but not a whole lot more data, unless somebody else has some further information.
Anyone else want to add it? So it sounds like it could do with a bit more work to understand that.
Yes, absolutely.
Please.
Hi, thank you very much. My name is Janet Fleischman with the CSIS Global Health Policy Center. Thank you for your presentations and for shedding light on all these important issues. I wanted to bring it for a second to the policy level. Obviously, there's important work that's being done on the national level, and Helen has referred to some of the new policies that are being developed in South Africa. But could you speak to other national level policies or donor level policies that are facilitating some of this integrated work, or that are blocking that work and that you're seeing as barriers to being able to pursue this? And just if I could throw in one last thing, I'm just wondering on the question of hormonal contraception, what you're seeing on the ground. Are women, HIV positive women, coming to you and saying, no, I don't want Depo anymore? Is this getting out, and are you seeing that on the ground level?
So who'd like to talk to the policy question? And donors, does anyone want to talk to that? Ward.
Well, as Janet knows, there have been several donors, including Hewlett and the Tides Foundation and others, that have specifically sponsored, and of course, the big three donors, USAID, NIH, and the Gates Foundation, that have actually funded studies looking at the most efficient way of integrating family planning and HIV services as we move forward in an attempt at health system strengthening and horizontalizing the care, so to speak. And then through PEPFAR, we've had a variety of programs at this conference, including one last night that the moderator will sum up for us in terms of what have been approaches and successes and barriers to further integration. So I don't know if you've had a chance to go to those, Janet, but there are many attempts out there, and we're gaining experience. It's not a slam dunk in every country, in every context, but I shouldn't go on when Helen summarized it last night.
I mean, the one thing I would add to that is that discussions like this, we've had different forums in this conference to have different types of discussions around this broad issue. This starts to drive processes. Last night we had somebody from DFID there, someone from Irish Aid, people from USAID. This starts to, this is a process. It's a continuum of thinking. Certainly if you look at the Netherlands, they have an ambassador who used to be ambassador for HIV. She's now the ambassador for SRHR and HIV. We have the opportunity with the London Declaration around family planning, and I'm quite certain that people are not going to say we're going to ring fence here, just as PEPFAR is no longer saying we're ring fencing that way. So I think that this is a continuum, and the more dialogue we have like this, the more people are going to actually say we need to be supporting these initiatives. Thanks. Please.
Chris O'Connor from Baseline Magazine in London, England. A question for Vivian about the 44% sterilisation rates in the Atlanta clinic. Did you discover what, I mean, that seems incredibly high. Was there anything behind that? And another point was looking at the three studies in the UK, South Africa, and in the US. It seems like the problem is not confined to the developing world, but especially the UK rates of unwanted pregnancies and terminations were the highest. And also one final point, while I've been standing here looking at that sign, sexual and reproductive health rights of women live with HIV, and also men live with HIV, and couples live with HIV. And I think that aspect has been missing in action in 2012, especially after last year's 052 trial. And that image that Nellie gave of the man sitting outside on a chair while his partner's in with you, that man's got to be in that room now, you know, and I think that any debate of those issues, especially when it comes to assisted conception, seems to be missing a little bit.
Viv? So thanks for the question. I think I chose those cases really just to illustrate different points, and I don't believe that the rates of sterilization would be found across states, but I think it might also reflect the age of that cohort. And you might find that when HIV first came out, you might have found there might have been a much more rigorous encouragement around sterilization. And certainly times have changed. And I don't think you would see that across the board now. And I think that's a historic thing, I hope, at any rate. I have learned, one thing I've really learned at this conference is that a lot of the problems we experience in sub-Saharan Africa are not sub-Saharan African problems, but they're world problems. And when I spoke about the different economic approaches to managing discordant couples, I was even thinking, here in Washington, a lot of our strategies for the poorest of the poor would be relevant, and you would use the minimum standard of care because that is what resources are available to those people in those communities. And I think we're becoming smaller and smaller in terms of our common problems.
Thank you. And the point about men is very well taken. Thank you. Last comment, please.
Yes, I'm Nyanda Labor with Planned Parenthood Federation of America's Africa Regional Office. And I'll just like to add on to Nellie's comment that she made about family planning practitioners being able to talk to women with HIV. In Kenya, we know that there are so many VCT counseling centers, and I would like us to also think about those VCT counseling centers where many positive women show up for the first time. The practitioners there are also able to talk to women about their fertility intentions and provide family planning counseling right there on the spot.
Thank you. So I think we've had an excellent discussion. I'm just going to pick up a few things as we close that I think have come out. This session was about the role of fertility choice in HIV prevention. And it's absolutely clear to me that the rights issue is once again coming out very loudly as underpinning this. I mean, I'm struck not only by the extremes of, for example, examples of forced sterilization in Namibia and some of the experiences that Angelina shared with us, but I think that the DMPA single method choice and availability is also a rights issue, because where has our voice gone to say that that isn't acceptable? And we also have to say, where are the methods and the available methods most limited? It's throughout the world, whichever community, it's poor women. It's poor women who are not actually accessing a range of methods. So there are many rights issues that are actually underpinning this. The second thing that struck me is there is a real paucity of data on the issue of fertility and choices, just as there is a paucity of programs. We haven't thought about this, but in the hyper-endemic countries, we have literally millions of women every year choosing to get pregnant in the absence of any programmatic intervention that is going to be aimed at them and their partners. So I think that this is going to be a new challenge, and in the next 5 years, I think that we will see this being increasingly addressed. And as Viv said, that treatment on the one side, and this is where the male partner becomes very important, but also PrEP. The third thing I think that's come out very loudly again is the community as a resource. Because if we are going to start getting women to either demand their rights, to be more aware that they can actually get contraception, and or that they need to think about fertility intentions, we can't do it in the constraints of our resource-poor settings with the staff that we've currently got. And actually engaging communities with the examples that we heard, and actually pulling in lay people to actually talk about experiences and to be trained to actually share information has to be a first step. So I think with that, it's been an excellent session. The 4 speakers were superb and all built on each other. And thank you very much for excellent questions.